Deficiency Anemia. Iron deficiency is the commonest nutritional deficiency in the world. Iron is essential for synthesis of heme component of hemoglobin. Iron is distributed as functional and storage forms. Functional component, which forms around 80% of total body iron, is found in hemoglobin, myoglobin, and iron-containing enzymes like catalase, cytochromes, etc. The storage pool, which is helpful when there are increased demands of iron, comprises rest of the 15 to 20% of total body iron. There are two storage forms of iron, namely ferritin and hemosiderin. Ferritin is mainly found in liver, spleen, bone marrow, and skeletal muscles. A fraction of it is present in serum, which can be used as a diagnostic tool, as you will see in later part of discussion. Hemosiderin, an aggregate of iron and protein, is found in liver, spleen, and reticuloendothelial cells of bone marrow. Daily requirement of iron is lower in males, that is about 5 to 10 milligrams per day, as compared to females, which is 20 milligrams per day. Good dietary sources of iron are red meat, poultry, green leafy vegetables, dry fruits, peas, etc. Heme in animal products is better absorbed as compared to non-heme or inorganic iron found in vegetables. Iron is absorbed from duodenum and proximal jejunum. Iron in non-heme form is to be reduced from ferric to ferrous form. This is accomplished by ferrireductases. Divalent metal transporter 1 helps ferrous iron to be transported across the brush border of the cytoplasmic membranes of enterocytes. Ferroportin 1 helps in the transport of ferrous iron from the cytoplasm into the circulation. Transferrin produced in liver is the iron transport protein in the plasma carrying iron to the erythroid precursors for hemoglobin synthesis. Iron balance is maintained by regulating its absorption in the gastrointestinal tract. Hepcidin, a protein synthesized in liver, controls the absorption and storage of iron. Hepcidin binds to ferroportin, thereby inhibiting iron transfer from enterocytes to plasma. Etiology of iron deficiency: increased demand, growing children, adolescents, pregnancy and lactation, decreased availability, low socio-economic status, vegetarian diet, milk-fed infants, breast milk has low iron content, elderly, improper diet, poor dentition, total or partial gastrectomy, leading to lack of gastric acidity and decreased transit time through duodenum. Intestinal diseases like spur. Dietary ingredients like phytates, tannates, oxalates, phosphates impede iron absorption, increased losses. Chronic blood loss due to bleeding peptic ulcers, gastric carcinoma, hookworm infestation, menstrual losses, genitourinary bleeding. Pathogenesis. There are 3 progressive stages of iron deficiency anemia. Stage 1. Iron depletion. In this phase of iron depletion, iron levels may be adequate and maintain the hemoglobin levels, but the serum ferritin levels decrease. Stage 2. Iron deficient erythropoiesis. Serum iron and transferrin saturation are decreased with progressive depletion of iron reserves, but still other RBC indices such as HB, MCV, and MCH are maintained. There will be signs of iron deficient erythropoiesis in bone marrow. Stage 3. Iron deficiency anemia. Progressive depletion of iron stores accompanied by low serum iron, serum ferritin, and transferrin saturation results in anemia. First morphological change to occur is microcytosis, that is, reduction in cell size, and next is hypochromia, which is an increase in central pallor. During normal hematopoiesis, an increased hemoglobin concentration in cells inhibit the cell division of normoblasts. But once hemoglobin is deficient, cell division continues, resulting in small-sized cells, that is microcytes. In severe cases, due to ineffective erythropoiesis, it is not uncommon to find misshapen erythrocytes termed as poikilocytes. Clinical features. The symptoms of anemia are insidious in onset. It starts with non-specific manifestations of easy fatigability or weakness, palpitations, shortness of breath, irritability, and loss of concentration. Some patients, especially middle-aged to elderly females, may have dysphagia and atrophic glossitis, that is bald tongue. Dysphagia is due to esophageal and post-cricoid webs, which making it a triad of Patterson-Kelly or Plummer-Vinson syndrome. Patients may also have an abnormal craving for substances like clay, chalk, or ice, which is termed as pica. Severe cases may be present with congestive cardiac failure due to hyperdynamic circulation. Then, there will be symptoms of the underlying problems such as bleeding from GIT, or genital tract. On examination, patient may have pallor, flattened nails, that is Platinaceae. Ridged, brittle, spoon-shaped nails, that is Coilonaceae. There can be angular stomatitis and glossitis. Laboratory findings. When hemoglobin is decreased, usually it falls in the range of 6 to 10 grams percentage in moderate cases and can be as low as 3 grams percentage in severe cases. Hematocrit is reduced usually to less than 30%. Red cell indices. Mean corpuscular volume MCV is reduced to less than 80 FL. Mean corpuscular hemoglobin MCH is reduced to less than 25 pg. Mean corpuscular hemoglobin concentration MCHC is reduced to less than 27 grams per deciliter. Red cell distribution width RDW is increased. It is one of the earliest signs. Peripheral smear examination. Red blood cells are microcytic, that is small, and hypochromic, increased pallor, more than 2/3 of the cell diameter. Platelets can be increased especially if patient is bleeding. Reticulocyte count is low but can be normal and may increase with treatment. Bone marrow examination shows a hypocellular marrow with increased erythroid precursors, termed as erythroid hyperplasia. The normoblasts are smaller than usual and have basophilic cytoplasm. This is known as micronormoblastic maturation. Stain for bone marrow iron by Pearl stain or Prussian blue reaction show low or absent iron in the hallmark finding and often termed as gold standard for the diagnosis of iron deficiency anemia. Serum iron profile in a patient with iron deficiency anemia. Differential diagnosis. Differential diagnosis of microcytic hypochromic anemia includes thalassemia, lead poisoning, drugs, etc. Patients with thalassemia major have features of hemolytic anemia and hepatosplenomegaly. Their iron stores are increased. In anemia of chronic disease, patients have an underlying chronic disorder. Their iron stores are normal or increased.